We also have a WhatsApp group and a YouTube channel, as you can see. I'm just going to share the links to both our WhatsApp group as well as our YouTube channel for you, so that you can all join in, because we keep updating our WhatsApp groups regarding our upcoming webinars. As you all know, that we have got an ongoing course on on neurosurgery for medical students at the level of junior neurosurgical trainees. So we have actually started up this course, and we have completed 3 modules already. However, you can join in. It is a certified course by the WFNS Education and Training Committee. So I think that we just completed our 3rd module last week. Just feel free to join in. We will be really happy. We are trying our best to make it possible to teach all the fundamental basic knowledge of neurological surgery and we will advance it further, one step at a time. So I think that it's going to be something that you would all appreciate. I'm going to share our WhatsApp group address so that you can all join in. We will be really pleased to have you all. We keep updating. I also share our relevant study data in our we can I've just shared the link to our WhatsApp group. I hope you can all join in. We will keep updating our group regarding our upcoming events and also the relevant study stuff, like I just mentioned about the liquid biopsy, all these papers, the important papers of our speakers have been uploaded in these groups, so that you can all feel free to have a look and to prepare any questions, inquiries if you have, regarding these lectures that we have arranged. So it's a huge honor. I think it's going to be a wonderful learning experience for all of us. I'm now going to share the link to our channel. This is our YouTube channel. You can subscribe from this channel so that you can have a look on all the recordings that we later keep of our and all the recordings that we've got. I've just loaded one of them, so I will be shortly loading the other two. Greetings, Dr. Maureen. It is so good to have you, and you are from Nicaragua. Thank you so much for coming. It's a huge honor for me, and I think you are going to enjoy the talks that are going to follow shortly. We will have for Professor Paul Brandon Stock first. Again, thank you so much for joining in. Please stop your country of origin. We will be pleased to see you all here. So you are all welcome. Please feel free to write your names and your country of origins. I think we have got attendees from all over the world. It's a huge honor to be here, to see you all here, and to welcome you all. Great, you're Turkistan from Pakistan. That's my home country. Mexico, great. Yes, Mexico. I've got so many friends from neurosurgery that who come from Mexico. I think it's you've got some really wonderful academics side of neurosurgery. And I also know Professor Griselda. She's a wonderful women neurosurgeon. So she's quite an inspiration for the women neurosurgeons. We attend so many of your programs. Muscat, Oman. Oh, that's great. That's amazing. I think you have got Professor Shara Rajmani, who's quite active on the internet. I see his posts on, um, in the neurosurgical cocktail. He shares a lot of academic experiences. By the end of the course, please do drop your email IDs, addresses, so that we can just email your certificates off to the ghost. We've got about an half an hour to go. Thank you so much. Greetings from Aberdeen. Oh, amazing! Aberdeen has wonderful, a very good impression from us. Since there's a lot of research from Aberdeen, and in fact, there is one knot in general surgery that's called the Aberdeen's knot. So it's something that's very interesting for all of us to see. And Aberdeen is same. The neurosurgical department of Aberdeen is even very and neurosciences development especially. It's very active in that. Thank you so much for joining in. Great, you're from Nishtar Hospital, Multan. It's the big hospital, and many of our eminent Pakistani neurosurgeons have actually belonged to Nishtar Hospital. That includes Professor Iftikhar Raja, who was one of the pioneers of neurological surgery. Um, it's wonderful. From Guyana, the wonderful Dr. Marco. Thank you so much for coming. We got people from all around the world. It's amazing. It's great. So nice to see you all here. So we have got a little global village. While it's quite hard for us to, beat this pandemic that has caused a lot of chaos lately, but I think there is a blessing in disguise that at least you guys can come in and we can get together on this virtual platform, and we have got a lot to learn from each other and from the wonderful legends. Zainab, okay, yeah. Hello, Zainab. Thank you so much for coming. Welcome. It's good to see you here again. You've been quite active lately. It's great. Yeah, you're welcome. Please keep updated. I think you are in our WhatsApp group. Please join in so that you can just keep in touch with what we are updating. We have got a lot of programs in line. So I guess that you are in the WhatsApp group for the updates. You're welcome, Pitam. I think our PSN was also held last time in Multan. Unfortunately, I couldn't make it in person, but I get to know about. Our guest will be joining in half an hour. Just thank you so much for logging in, because I myself, when I'm logging in for any course, I just log in half an hour before, because just to make sure that the slots are not filled up, because there is a limit of Zoom launch. So everyone, I really appreciate people logging in early, because that really shows their level of interest. This is so huge, and that's what I see when I also have the same level of anxiety when I'm going to attend a course, something like this. So I usually log in half an hour before, like you all. So thank you so much for coming. I'm really really happy to see you all here and to welcome you all. I hope again, I want to advertise the course. I think you all know about the WCN MSMR course that we are running. It is a year long course. We have completed 3 of the modules. that is under the supervision and guidance and the direction of the WFNS Education and Training Committee. That is that is being chaired by Professor Luis Boba, and I think it's a matter of huge privilege to have his very kind guidance and direction all the way for this a wonderful course that we have designed for the level of medical students, the level of junior trainees. Welcome, John Bennett. I can see you there.
Greetings, Noor.
Hi, hi. How are you doing today? It's good to see you.
Okay, be careful what you say. You're live on neurosurgical TV.
Oh yeah, I'm grateful.
It's like the pre-game show.
Yeah, yeah, exactly. It's a pre-game show. I'm just welcoming people. There are amazing people out there. I was telling them that it is the same level of anxiety that I face when I'm joining a course. So I usually log
Greetings,
in.
Noor.
Oh, I can see the echo. I can hear the echo.
Okay, be careful.
So I can see myself. I can hear myself as well. So how is it
Atol's
going?
here. Atol's here. Hey, Atol, how you doing?
I cannot see him.
Well, I was able to send out to the mailing list and a lot of people that it started late. So I think a lot of people found out.
Yeah, exactly. So many people. I sent the email out for the renewed.
Yeah, you got two good lectures. So
Yeah, wonderful. I think I don't know, there was some inevitable emergency that was being faced by Professor Anila Darbar, so she had to postpone it at almost
oh, okay,
at,
we have a speaker here from Cuba. He's doing Cuba. Marco, introduce yourself to Noor. Marco from Cuba.
let me share. Actually, I've muted everyone. So Marco Baralt, you mean? Hello.
Example, I said, come to this webcast. Marco, can you please introduce yourself from Cuba? Actually, he's in Guyana now, which is a country in the north part of South America. Do you know what Guyana is, Noor?
Of course, I do.
Yeah,
Everyone
yeah,
knows. Yeah,
Marco.
yeah. It's a famous country.
Yeah, it's a
Cuba.
small country up north.
Yeah,
Marco,
yeah.
introduce yourself. Hello, Marco. Put your
I
camera
unmuted
on
him.
and say hi to Noor. Well, I guess it's not working. Anyways,
Dr. Harsh.
Zanab's here. She's from
Doc,
Africa. Oh,
just a minute. Dr. Harsh Part, it is going to be started soon. Actually, we started it early because obviously we had to log in. We have to open the room. So actually, it's going to start in
okay,
about.
Noor, good luck. I'm going to leave you.
Oh, really? No, no, you can just stay logged in. We can just invite and see who is coming up. I think he's logging in half an hour because the actual time was, about 24 minutes from now. I just
Okay,
opened the
24
Zoom
minutes.
room from now. Yes, exactly. So I opened the room in the same way you do.
Okay, let me go back to the internet and tell people about it.
Thank you so much. Thanks for
Thank
coming.
you.
Looking forward. I again want to invite you all to join the WhatsApp group as well as our YouTube channel so that you can just keep up with all the programs that we are sharing and having. This is, I'm sharing now in the chat box the link to our WhatsApp group. And this is our uh, YouTube channel. Okay, yeah, I tried to unmute Dr. Marco. I guess that did you get that message? I tried to unmute you, but I think you couldn't get that in. Dr. Marco, I guess I cannot unmute you. I'm trying to unmute you. Do you get that? There is a request that's being sent by the host. Uh, did you get that? I think there's some networking issue from here. I guess that liquid biopsy is a very new a very new concept. So I don't know how many of you have just quite heard about this liquid biopsy for brain tumor diagnosis. If you've got any ideas, I will be pleased to share it. Otherwise, we do have this lecture tuned in for just to introduce this very new concept in brain tumor diagnosis because it's going to be something that's going to revolutionize the diagnosis of brain tumors in a very non-invasive way. You just need to take blood out and have a spectroscopic examination and just diagnose the the glioblastomas. Great. So what's the topic? Great, Dr. Kitam, but what's the topic? I would like you to kindly write it down. We are really pleased to have our attendees over here. The meeting will be starting shortly in 17 minutes. I even actually plan to show up the tomorrow will be said. Okay, thank you. So is it a quiz-oriented study or is it a lecture or a journal club? I would like you to kindly mention that so that we can have a good idea. The meeting will be starting shortly in 15 minutes. Actually, I opened the Zoom room half an hour before so that we can actually get everyone in. Dr. Paul is joining us shortly, so just be prepared and feel free to share the meeting link with your friends and colleagues. It's going to be really interesting to discuss this very new concept today of liquid biopsy. And I think I've also loaded a few relevant papers, including the paper that's been written by Professor Paul Brennan himself. So I think that in the WhatsApp groups, I think you should also should go through those papers, and it's going to be a very amazing meeting today with him. And after that, we will have Professor Nader Sana himself to discuss the surgical strategies for insular gliomas. And all of us with in neurosurgery, we all know about the Berger Sanai zonal classification system for insular gliomas. As they, I don't think that Professor Nader Sana needs any introduction. So I think that it's going to be amazing. Just kindly stay muted during the lectures, and please do feel free to leave your questions in the Q&A or in the chat box. We will forward your questions to the speakers by the end of the session. And again, thank you so much for joining in, and please keep sharing with your friends and colleagues. And again, those of you who have just joined, I really want to uh, share that if you haven't joined our WhatsApp group, I'm just sharing our link again. Kindly join our WhatsApp group, and this is the link to our YouTube channel. You just go through this. We are also running a WFNS Education Committee course, the WC and MSMR course, and I think that you all know about it. We have completed three of our basic modules, and we are now remained with it's a year-long course, so we are going to have at least nine more, and even more than nine, since there was some topics that people had a high demand of it, but we actually had in mind that we are going to have these 12 modules. We actually set a curriculum for them. So Professor Luis Barber really wanted to teach all those basic things that a neurosurgeon needs to know and should actually be well equipped with while training with the neurosurgical patients on the neurosurgical wards. So he was quite, I think it's the dedication of professors like Professor Luis Borba, who is making neurosurgery, who are the cause of the progress of our field of neurosurgery. It was a brainchild of Professor Luis Borba, so he asked me to do, and I was so much um, pleased and honored to do so, since I've just completed my own training as well. So I had a lot of ideas regarding what we should be taught, and what we need to actually be taught for a better management and for our better performance on the neurosurgical floor. So we started out with the basics that includes neuroanatomy, followed by radiology, and then later on we proceeded with we just completed the neurosurgical approaches. Professor Barba again wanted it to be very precise and pinpoint and focused so that everyone can have a good idea. I just want everyone to be well equipped with the proper management of patients. So we kept it a little simple. We did not complicated it. However, we will be starting our new webcast on neurosurgical approaches shortly. I think because we have got an amazing feedback on that, and I will be pleased if you all just email us your suggestions of some particular program that you really want us to arrange, and we will be pleased to arrange. This is our email address. Feel free to drop us an email on any topic that you want to hear, that you want us to organize, and we will be more than pleased to have to arrange a meeting accordingly. We are open to all the suggestions, and Professor Borba is, I think, is very kind of him. He's looking after all the junior neurosurgeons and trainees and medical students equally. So he's like, I really I really appreciate it, the way he's doing it all. So I think your input will be very important. It's really important for us, really, so that we can have a great idea. So whatever is my own experience, I keep following, and I keep telling him that it could be something that I would like to listen to, and that was what I used to think about during my own training. So it's like my own reflection, what I could feel. So I think that it is time for you all to please share your all opinions and your suggestions. We are going to have our first lecture in 7 minutes. Okay, I just check my mic again. Dr. Paul, hello, sir. Welcome, Professor Paul Brennan. Hi.
Hello.
How is sir?
Good, thank you. Thanks for inviting me.
It's our honor and pleasure is all ours. Thank you so much for coming. It's a matter of huge honor and pleasure for us to have you here today with your amazing lecture on the innovative blood biomarker for brain cancers. I think this is a very amazing approach, and I think that not many of the people are well aware with this wonderful new concept. So again, thank you so much, sir. It's a huge honor for us to have you here.
Well, thank you. It's great to get to speak. I can see there's some people from the UK, from Scotland on the call. But I imagine there's many people from elsewhere as well. I'm just going to turn off my video and just load up my slides just now.
Yeah, sure, sir. I would like to have a little introduction over here. Professor Paul Brannan is Reader and Honorary Consultant Neurosurgeon at the Center for Clinical Brain Science and Cancer Research in UK Edinburgh Center and Edinburgh Center of Neuro-Oncology. So it's really amazing to have you here, sir. I've also shared your very wonderful paper in our WhatsApp group for all of our attendees to have a look. So, sir, this is I'm really excited myself to listen to this very amazing talk and this very new thing, a new concept in neurosurgery. So,
Sorry, no, could you just let me share the slides, please? They're just on.
I just, yes, sure. Can you share your slides now, please?
I'll check. Yep, I'll be with you in a moment. Cool. Right.
Perfect, sir.
Am I okay to start?
Yes, please do, sir.
Thanks. Well, yeah, I mean, thank you very much for inviting me. It really is good that people read what I write about beyond the confines of Edinburgh. So hopefully what I'm going to talk about will be of interest to you. I've mixed it up a little bit just to give you some of the context to the sort of research we do in Edinburgh. So you can see, hopefully that's interesting. But I'm going to focus on the blood test side of things, which hopefully is not a million miles away from the clinic and is something that's going to impact for patients. So I really need to update these images on the right, and these were the three computer-generated images of what our hospital would look like when it was built. It has been built, and it does look pretty much like that. And certainly Edinburgh looks like that at the bottom. It's a really nice sunny day today. So I don't need to dwell too much on the problem. We know, well, we all see these patients. We know how difficult it is to get a good outcome for patients. It's not difficult to treat them. It's difficult to get a good outcome. And often when I meet patients in clinic, and I'd be interested to hear, where the questions, whether it's the same for you. The first thing people say is, oh, I went to my doctor ages ago, or my brother went to a doctor ages ago, and no one listens to me. And if I had I got an earlier diagnosis, would that have made a difference? And that was for me one of the things that got me interested in diagnosis. And I'll just work through the logic behind that as a surgeon. But should we be doing something different? The biggest study that's made an impact was almost 20 years ago now. And if you think it was published in 2003, the Stuck paper maybe impacted on the clinic from about 2005, but the patients were probably from the late 90s. So we haven't really made a difference. And, I was interested in ways that we might try and do that. I just want to give a little bit context to where that journey started, because for us and the colleagues I work with in Edinburgh, we try and use patients as a model. So we do lots of laboratory research here, and there's some great laboratory scientists. I dabble in it myself in Edinburgh. But we're interested in what the patients can tell us. And when we're thinking about how to improve outcomes for patients, if the radiotherapy makes a little bit of a difference, if the chemotherapy makes a little bit of a difference, and maybe even surgery makes a difference, I wanted to try and understand what that looked like around the world. And my colleague, Michael Poon, who's another neurosurgeon, just completed his PhD in Edinburgh, did this work. We did a meta-analysis of population-based studies So if the study had reported more than 50 patients and it had reported a 2-year survival, he included these in the analysis. And if STUP was reported in 2003, then we took that, we said, well, maybe before 2005, people were focusing on other treatments, and after 2005, they were focusing on maybe giving people temozolomide. And there has been an improvement in survival. But this is across the whole world. So whether you think surgeons are good in one country or another, or you think oncology is good, or you think diagnosis is good, the actual, the survival differences for patients has been very similar. 2-year survival, 3-year survival, very interesting that there's not much happened at 5-year survival. Now that might be an element of underreporting because it's harder to get data on the smaller number of patients when people report these studies. But really, that's just the context, that there isn't an obvious thing that other people are doing better. We're all pretty much doing the same around the world, although with different resources. And there's a follow-on question that Michael asked related to that, because we often say, well, brain tumors are increasing in incidence, and it's not unusual to occasionally read an article in the newspaper that says mobile phones cause brain tumors, or mobile phone masks cause brain tumors, or anything causes brain tumors. And if you look at the sort of, in the UK, this Wales data, Wales collects really good data in the UK. We don't collect a single set of data for the whole United Kingdom. Each of the individual countries or nations collects its own data. Wales collects really nice data. And just to summarize what these graphs show, so the first panel on the left, and the top solid black circles, so that's all reported brain tumors. So someone says, this patient has a brain tumor, that gets logged somewhere. And the line at the bottom is the people who actually get surgery to prove that. So there was a gradual trend over the years of more people having surgery, probably at a slightly faster rate than the total number of patients who had brain tumors. So we're maybe getting to these patients sooner, diagnosing them sooner, and operating on more of them. And so, you know, headline news, brain tumors are going up, this is a problem. And the panel in the middle is, if we just look at the grade 4 gliomas within that population, certainly it gives the impression that the grade 4 gliomas are going up. So if we've got tumors going up, we've got grade 4 gliomas going up, maybe we've got a real problem, maybe it is mobile phones. But the key bit of the data analysis, which Michael did, was in the third panel. And that's really to say that at the same time as the grade 4 gliomas are going up, the other grades of gliomas seem to come down. And there's lots we could unpick in this data, but there's just 2 key messages. One is that it makes a difference whether you actually take a biopsy and get the histology of the patient. And the vast amount of data that's out there about brain tumors is based on clinical information and not on histology. But the other bit of information is that we are as a community diagnosing tumors earlier. So if we're diagnosing tumors earlier, why are people not surviving better? And that sort of, you know, that story of survival differences around the world aren't really changing, but we're picking up tumors earlier, why are we not making a big difference? That brings us on to the failure at the treatment end. Okay, so we're not making a difference with new drugs. There's stuff out there, there's no shortage of clinical trials. We could talk through all sorts of reasons why these fail, but they are failing. And I sort of, you know, years ago summarized this in my head, which was, well, we can't make the patients younger. A younger patients seem to do better than older patients, but we can't make them younger when they come. We can't make them fitter, perhaps. Well, we can give them steroids, we can get to their tumors earlier. Maybe that does make them a bit fitter when they come to surgery. And the molecular features, whether that's MGMT status or IDH mutations, you know, they're all preordained in the tumors. But there's a few things that we can do things about, and we can take out more tumor. And I've included Stummer's figure in the bottom right. It doesn't prove that you live for longer, but you certainly have good progression, better progression-free survival if you take out more tumor. We can make people fitter before they come to surgery. But we could diagnose things sooner. And so of all the things that we can do as surgeons, taking out more tumor, making the patient fitter, helping our colleagues in primary care and elsewhere in the hospital diagnose tumors earlier. These are the sorts of things that my focus has been on the clinical side of research, to try and improve outcomes for patients. I'm just going to touch on bits of all of those. So extensive resection, really just to flag up a piece of work we did, and maybe some people on the call were involved in this. So Stummer showed that if you give people 5-aminolevulinic acid or glialan, that the tumor sometimes glows up pink, and you can often take out more tumor than you otherwise intended to. But clearly, you can take out more of that right frontal tumor on the left panel than you can of the one that goes across the corpus callosum. And so the extent of resection argument is much more nuanced than simply taking out more surgery, taking out more tumor. And I think there've been a couple of great studies over the last few years looking at this, some good meta-analyses. But the one that the sort of the bit of information which is probably most important is that the time at which you do the second surgery is probably one of the important predictors of the outcome, rather than the fact of doing the second surgery. And so we looked in the UK at that. We got data from quite a few of the big or busy units in the UK, and we tried to develop some consensus guidelines for how to decide which patients to do second surgery for, really as a prelude to try and do a randomized controlled trial. And we published that paper earlier in the year, which is what's interests me about it is that it's been interesting to people in other countries when we talk about how long patients should have survived from their first surgery, or how much of their tumor we should hope to get out. So the extent of resection as a story to improving outcomes, I think that's still there for neurosurgeons to do better. I don't think it's totally resolved as to whether it makes a difference, but there's probably a real need for some trials. And so that's an area in Edinburgh that we hope to do some more work on. But I'm going to focus on the thing I said I'd talk the most about, and about this blood test. And I hope that context is useful as to why a neurosurgeon is interested in this, because we don't do the diagnosis in the UK. We get usually primary care doctors, sometimes ED doctors to do that, but not ourselves. And it's partly because I recognize how important it is to improving the outcomes of the patients I end up operating on that I got involved, but also because I think it's a very tractable problem. One of the arguments I make is not that I can make people live forever if you diagnose them sooner. Clearly, a glioblastoma is still going to kill someone. But if you operate earlier when a tumor is smaller, then I think the outcomes for patients can be better. And I'd be interested to hear whether how the statistics compare in the countries you're from compared to the UK. But often patients visit their GP lots of times before they get a diagnosis. Most of the route into the hospital is through family doctors. You go to your doctor, I've got a headache. Oh, don't worry, you're stressed, busy at work, problems at home. Come back a couple of weeks later, headache still bad. And you go through that cycle, you develop a few more symptoms, you become a bit confused, you forget things. And eventually something's going to happen. You might have a seizure, you might develop a weakness, and you go to the emergency department. And we have an excellent primary care system in the UK, but for all the consultations people have, 2/3 of patients are diagnosed in the emergency department. So we've clearly got a discrepancy between the patients who are going to their doctor and the patients who are presenting to the emergency department. And why is that? What can we do to help GPs make the diagnosis earlier? And one thing we thought we could do was to help with symptoms, because the difficulty is that patients present with non-specific symptoms. If you have a seizure, you'll probably just go to hospital. If you develop a weakness of your arm and leg, you'll probably just go to hospital. If it's a sudden onset thing, you might think you've got a stroke, you find out you've got a brain tumor, but you'll get to the hospital. The difficulties for the patients with the headaches, with the confusion, with the personality change, with the very subtle things which are much more likely to have a non-specific cause. And we looked at a vast amount of data, 8,000 patients with tumors, 28,000 patients who didn't have tumors, but went to their doctor on the same day that the person with the tumor. So we tried to match the patients in that way, age and data presentation. And we'd hoped that you might be able to say, well, if the patient's over the age of 35 and they're male and they've got a new headache and the headache's lasted for 5, we thought you might be able to build up these predictive models of symptoms and patient features, which would make it more likely they've got a diagnosis. And we just couldn't do that. We looked at the data in lots of different ways. We assigned scores to all the different symptoms. We grouped them together, but the PPVs, the positive predictive values you see there, really show that these things are no better than useless. You know, just because you've got a seizure, weakness, and confusion, you've got a 1.4% chance of having a brain tumor. Well, if you've got a seizure, weakness, and confusion, you're probably going to go to hospital. So it's no use that I can tell you it's a 1.4% chance. You'll just go to hospital and get a scan. And really, nothing was really better than that. Headache on its own is obviously rubbish. That's not a surprise. One thing that was interesting is that if you had headache to a cognitive change, so I've got a new onset headache and my brain's just not working as well, then actually the predictive value goes up to 7%. Now that's still not great, but of all the things we looked at, that was one of the best things. And I'll come back to that in a minute when I'm talking about solutions to this problem of diagnosis. Another thing we did was look at who GPs actually did think had brain tumors, because you've got this population of people who are going to the GP 5 times before they get a diagnosis, and you've got 2/3 of all patients with a brain tumor are only getting diagnosed when they go to the emergency department. And what's the connection between those two groups? Because GPs must think some patients have brain tumors because we get referrals. Well, I guess we don't, but the hospitals get referrals. Patients get sent for scans. They go and see a neurologist. In Edinburgh, the way that happens is the GP says, well, I think there's something wrong with you. I don't think you have to go into hospital tonight, but I'll send you for an urgent scan. And people get these CT scans. So we looked at 3,000 of these patients and we classified their symptoms according to a thing called the Kernick classification, which is just about red flag, orange flag, and yellow flag symptoms. And what we found was that the only symptoms that actually predict patient outcome were the really obvious things. So red flag symptoms are, you know, I've developed a weakness in my arm, or I've just had a seizure. And again, you don't need to help a GP figure out that patient needs a scan. So symptoms alone are not working. The patients that GPs are referring for scans have usually not got a tumor. Only 2% of the 3,000 patients they referred actually had a tumor. So the patients they think have a tumor don't have a tumor, and the patients that do have a tumor are going to the emergency department. So we're just building up the evidence base for the problem. The wrong patients are getting scans. The patients who've got brain tumors are getting delayed. Delayed patients leads to bigger tumors leads to poor outcomes. So what can we do? And so on that cognitive side, perhaps we could do a cognitive test. And this is a bit I'm not going to dwell on, but there's a test called the verbal fluency test, which if you've ever done the Addenbrooke's cognitive assessment, it's a component of that where you ask patients to name as many animals as they can in a minute. I don't give patients warning of it. I just say, I'm going to ask you to name as many of something in a minute. I'm going to start my watch and I'll tell you what it is. Right. As many animals as you can in a minute, go. So that's semantic verbal fluency. Phonemic verbal fluency is when you say, can you name as many things beginning with a letter, for example, the letter P. But what we found was that semantic verbal fluency is much lower in people who have brain tumors. And this is just an example. A patient who the GP thought had a tumor because they had headache, and a patient who the GP who had a tumor and had headache, if that makes sense. So GP referrals with headache but didn't have a tumor, patient who does have a tumor and does have headache. And we found that the verbal fluency was significantly different in the two groups. And so a patient with a new onset headache, a new onset cognitive change, who also has a reduction in the verbal fluency scale, actually now you've got a way of accelerating that patient into the clinic. And that's one way we're working. If you live in Edinburgh and you're a GP, that is the current system for getting an urgent CT scan. But we probably need to do a lot more work on that to figure out how useful it is and how reliable it is in different populations. So we need a blood test. And I hope I've explained to you why you end up needing a blood test, because all the other strategies we've tried help a little bit, but they don't help a lot. And over the last 10 years, I've been involved in various different strategies for trying to find things in blood. And the thing you often hear about is people looking for bits of DNA. Oh, well, the tumor is full of DNA, it's DNA gone bad. If I could find a bit of that DNA in the blood, then maybe I could tell that someone has a cancer. And all the data that's out there, and I'm not specifically going to go into this today, but I'm happy to tell people more about it. But people have published lots of data that shows that you can't find DNA from brain tumors in patients. that's a gross summary, but you can find it in lung cancer, you can find it in colon cancer and prostate cancer. It's very difficult to find in brain cancer. Maybe it's something to do with the blood-brain barrier. It's even more difficult in early stage disease. So although you can detect 92% of people with lung cancer have lung cancer DNA in their blood, only 18% of people with a grade 1 lung cancer do. Okay, so the metastatic's 92%, the grade 1 at 18%. So simply trying to detect bits of DNA doesn't work. A chemist called Matt Baker in Glasgow came up with the idea of using infrared serum spectroscopy. So you take literally a drop of the blood, you put it on a crystal or on a different type of internal refractive element, and he's invented a silicon-based one, which is very cheap, much cheaper than diamond ones and much easier to use. You fire your light into it, you create a spectra, you take 1,000 people with a brain tumor, 1,000 people without a brain tumor, and you just get a computer to crunch the spectra. And what you eventually end up with are differences. And that's what I'm trying to illustrate on the figure down here, is that just in, I don't know if you can see my my pointer, but where the big blue spike is, there's a slight separation between the red and black lines. And so there are features between people who have brain cancer and people who don't have brain cancer, which are different. And we've done several studies on that. And we can tell the difference reliably between these patients. So the patients come into hospital either because they're referred by the GP, or because they present to the emergency department, or because they know they have a tumor and they come to me. We take blood samples off all of them. We've got, a couple of thousand blood samples so far. We anonymize them all, and then we get an independent person to analyze them. So, it's not a randomized controlled trial, but this is blinded data. And the sensitivity is high. We can pick up glioblastomas, and I'll show you a slide in a moment. We've actually gone higher than 92, and the specificity is not bad either. So that's the same slide. This is the latest data, where rather than just asking the test to the computer and machine learning algorithm to come up with the best result it can, we actually say come up with the most sensitive test you can. And 96% sensitivity is really impressive. When you remember that headache has a 0.2% ppv, even headache and cognition is only 7 point whatever percent. This is a profoundly sensitive test. Now, the slight downside is that the specificity is only 45%. What that translates to in real life is that for every patient who has a positive blood test, for every 2 patients, only 1 will have a tumor. So we're going to end up scanning more people with this blood test than we would do if the specificity was higher. But we'll scan far fewer patients than if we just base it on symptoms. So if we now say, well, I've got a patient with symptoms, I've got a patient with a verbal fluency test, I've got a patient with a blood test, we're getting pretty far down the line of being able to say, I can, if you've got a positive blood test, you should get to hospital, you should get a scan as quickly as possible. I put the data at the bottom for specificity just to emphasize that you can train the algorithm to be specific. So you can reduce the number of false negatives. And so you can reduce the number, false positives. So you can reduce the number of people who are inappropriately getting an MRI or a CT scan, but then you lose sensitivity. It's interesting, though, that some of the big cell-free DNA studies are focusing on specificity rather than sensitivity. So they're trying to pick up a few patients, but not cause lots more investigations. But then the cost of that is sensitivity. But our sensitivity, 47%, is still better than GRAIL, which is running at 18% at the moment for the early stage tumors. And there's other slides I can show you that we can pick up tumors down to 0.2 centimeters cubed, so we can detect early stage, low grade, and small tumors. But this is just a slide I put up just to emphasize, in our clinical practice, do you know what sensitivity and specificity applies to all the tests you use? I must admit, I had no idea till I got involved in this. Things like PSA. We rely on it for prostate cancer. When you guys get to a certain age, this is a routine test. It's just not that good. And because it's not that good, 20% specificity, lots of patients go for invasive procedures on the basis of the PSA, which turn out to be negative. It costs a lot of money, it's uncomfortable, and every so often a patient gets harmed from it. So actually, the high 90s, high 80% sensitivity and specificity for this blood test is really transformational. And it will get better. The more patients we put in, the more different types of tumors we put into the training database, the better the test will be. And this is the numbers from the first paper. and GBM really dominated. We're now getting many more meningiomas in there, many more metastasis. And so over time, that performance will improve. And what we have been able to show is not only can you tell that someone has a tumor or not a tumor, you can tell what sort of tumor they have. I think this could be profoundly useful. It's not the same as saying you definitely have this tumor or you definitely don't have the tumor. But in those patients where we're weighing up options, for us, lymphoma is important. We have a fairly strict age cutoff about whether you get chemotherapy for primary cerebral lymphoma. And if you've got a GBM, you might be less likely to get treated above a certain age than for a patient with lymphoma, or vice versa. It depends on a few different features. So if we can tell with a high sensitivity and specificity that this patient probably has a glioma or probably has a lymphoma, then we can do a lot for patients. And we've done that over a whole load of tumors. And there's a lot of data here, but it's all public. It actually says in review, but it's published now, this data. So I think there's something really profoundly useful in being able to categorize cancer versus cancer, go for your scan, and then before you go to see your surgeon, before you go to a multidisciplinary meeting, we can tell you, well, probably you have this tumor, probably you have that tumor. And it'll be interesting over time to see whether that can impact on patient care, because it's a different mindset. Because we don't have that information at the moment, we're not replacing something we already have. We're adding information, and actually clinicians learning how to use that information can be quite difficult. We're also looking at how you make the test performance even better. So we've got strategies for putting more blood samples in and making the spectroscopy higher fidelity. But we're also looking at ways of adding in other electrochemical tests. So this thing up in the top left-hand corner that says ClinSpec Diagnostics on, this is from the company who makes these things. It's about the size of a standard microscope slide. But what you can imagine is that you would do your infrared spectroscopy on one bit, and then you could have an electrode biosensor on another bit, maybe for a protein, for a cytokine or something. And this can all be done very quickly. So the spectroscopy test, you take a blood sample, you spin it, you aliquot the serum, and you get your result within 10 minutes. So this is very different from having to sequence genes, very different from having to purify bits of DNA from blood. And so this is not quite near patient, but it's, patient-centered, rapid, low cost. And this is where we're heading, okay? That patient with symptoms gets a triage blood test before they get the diagnosis. And hopefully, let's bring the diagnosis earlier for patients. Patients may think they survive longer, and there'll be statistics out there that say they do, because we introduce a lead time bias. So no one needs to tell me about lead time bias. I get that we're just going to increase lead time bias. But for at least some patients, we will improve their prognosis. And for those patients who do get surgery, we should make the surgery safer, and the chemotherapy safer, and the radiotherapy safer. So whilst we're waiting for other clever scientists to come up with new drugs, we can keep the patients that we do have safer and healthier, so they'll be in a better position to have the drugs when they become available. And if you think about the immune therapies coming on stream, getting a diagnosis earlier so that you can have your neoadjuvant therapy up front is actually probably the way to go. So this is about positioning ourselves for the future as well. And just the final slide, you might be thinking, well, could you not do this for other cancers? And of course you can. So we've done this for a whole series of other cancers: lung, bowel, pancreas, ovarian, breast, prostate, and that data is under review now. So now we've got a blood test which you can do on someone with any non-specific symptoms, which will tell you whether you've got any of these cancers and tell you which of those cancers you have. It's not a diagnostic test, it's a triage test. It will guide you to where to send the patient. But I think however you look at that, that's going to be pretty life-changing for patients and hopefully for doctors as well. So thanks very much for your time. I hope that was interesting. And I think if Noor's happy, I've got a few minutes to answer some questions.
Thank you so much for the amazing talk. It was wonderful indeed. And actually, we all liked it so much. I tell you that, in fact, many people are still not quite aware of this type of research in neurological surgery. And when I first came across this, I was really intrigued to have this concept, which is really minimally invasive and very practical. So how do you see things for it to be, how do you see that this will be applicable on a wide, on a broader range?
Yeah, I mean, a bit. There's lots of facets to that. I mean, one is, does it work in different countries? Does it work in different, geographical locations? And Scotland is a very white Caucasian population. It works beautifully. We need to move outside of that population, and we're trying to do that. We're trying to engage people in different countries, and if there are people out there who could run these sorts of prospective validation studies in different countries, and it would be really interesting to work with you. We in the UK, the route to getting this into the clinic is slightly psychological. We've got to
Yes,
convince
exactly.
people that it's useful. There is a regulatory
Um,
process. We will meet the requirements to go through the regulatory process, but will people actually use it? And so I think part of putting together this evidence base is about creating a narrative so that people want to use it. So I think that's important. And then the other part is, does it really work? And we just need to take it out into the real world and see.
Yes, exactly, you're exactly right. And obviously, I think that it is quite, it's very important to promote this type of research for everyone, at least to have a meta-analysis, even if they cannot conduct it in their centers. At least people should be well aware of this. And I think this will be a game changer indeed for brain tumor diagnosis. And I also read that it is, as you have mentioned, I think in the presentation and also in your paper, that it is quite cost effective, that it is not going to be quite expensive on the system. Am I right?
Yeah, I guess just to emphasize that I have nothing to do with the business. So the people
Yeah.
who actually commercialize this
Yeah.
are separate. So I try and separate it out, because otherwise you might not believe the science or the research if I
Yeah.
was about to become a billionaire. I've been pretty clear about this. I don't think it's going to work unless it's low cost. It has to be something that could be used on lots of people, lots of times. So if you think about the problem at the moment, is the people who we think have brain tumors, only 2% actually have them. Whereas most people who have a tumor, we never even think about it. They only find out they have a tumor when they get worse. It's really important that. So the only way we're going to improve the diagnosis for most patients is to do a blood test on people who we don't think have a brain tumor. Okay, so those people with headaches who we don't think have a brain tumor, they need the blood test. The people with non-specific head symptoms of whatever sort, they need the blood test, because that's the only way we're going to pick these things up. And so if that's going to work, it needs to be cheap, because otherwise no one's going to do it. And so I think that's the challenge to the business guys, to the investors, is make it as cheap as possible so people will use it.
Exactly. So that's really important for for a huge majority of people around the world, that either it is affordable or not affordable, but it's obviously very practical. And I can tell you that what I can see from it, that is very important to rule in and to rule out the pathology. I can tell you from my own experience that one of my friends, her relative was suffered from an episode of severe headache, and he presented to the hospital, and he underwent the CT scan and scanning, and it was so shocking for them that the neurosurgeon who was attending, he said that he has got a high grade glioma and he needs urgent surgery. So she dialed me in. I was not in town, so I was abroad. So I thought that I can't unfortunately attend to your patient, but you can just share me his reports. And I was so amazed that he was misdiagnosed, and what I found, he had a venous infection. He had a simple venous infarct, and I told her that it's a venous infarct and it's not any new plastic procedure that's taking place. And she replied to me, I wish there was a blood test to tell this, because here they are causing a lot of confusion, and they are just constantly saying that it's a new plastic procedure. And when I said that you should just confirm it with an MRV, or anything, that venography, just go for the venography as well as the MRS. And I was amazed to find that even after that, many people misdiagnosed him, and he ended up, as I suspected, that he had SLE. He had systemic lupus erythematosus, and he had a venous infarct. And unfortunately, we were able to wheel him out of the OR. Literally, we have him wheeled bailed out of the operating theater. Otherwise, he was misdiagnosed. So I think that something like this, a blood test might be able to provide something a good basis for the initial testing instead of going into radiological examination direct on and followed by misinterpretations by people who might not be, I think, might not be much well versed or who have got a lot of experience, so they just cannot rule it out that it was not a neoplastic procedure. It was very, to me, it was a classical venous infarct, but it was obviously something that was very serious for us. I think this could be a big opportunity that a blood test can provide. Like you said, that I wish there was a blood test and we had undergone it. Thank you so much. I think we have got a couple of questions. Um, Harsh Bhatt has sent you a super interesting. Thank you so much. As described, if it is not cancer cell in the blood with the spectroscopy, is stratifying patient by what are the cells or the serum proteins or constituents that is split by them, and is presumably that spectral signature changes over the disease or treatment journey, as well as, for example, the low grade versus high grade gliomas, which is a recurrent high grade glioma was it the treated high-grade glioma, etc.? Should I repeat the question to you?
No, that's good. No, it's a great question, and I'm sorry I dwelled at quite a high level. So many of us will have heard of mass spectroscopy, and if you do mass spectroscopy, you can resolve exactly what you're looking at. So you get an exact weight, and you can work out what that is, what that element is, that compound is, whatever it is. With infrared spectroscopy, you can't do that. So you can't tell what each peak in the spectra signifies. You can work out bonds, like chemical bonds, but the resolution is no better than that. So we're picking up, we must be picking up bits of tumor. People say that there are tumor cells in the blood, that there are exosomes, that there's DNA. So we'll be picking up all those things, but we're just not resolving those things. So we don't know that what they are, or we don't know they're there. We just know that they're somehow contributing to the signal. But there's also this systemic response to cancer, and that links into my laboratory research in terms of the sort of intercellular signaling that goes on. We think about how tumor cells signal with each other, but tumor cells also signal with every other cell, and that's that signal goes into your systemic circulation. So we're picking up non-tumor cell factors in the blood, and whether it changes over time is a good question for an individual patient. It doesn't change between patients hugely. So the fact that we can resolve an algorithm with 96% sensitivity suggests that there are patterns which are consistent, and we can do that across pilocytic astrocytomas, oligodendrogliomas, anaplastic. We can do it along the whole thing. We can do it from meningiomas, but there are gaps, and the gaps are interesting. There aren't there aren't neurocytomas in there, grade 1 neurocytomas. There aren't lots of incidental meningiomas. So whether those tumors have signals, whether we can pick those things up, I think that'll be really interesting. I expect not, because if you're not generating a systemic response to the tumor, then why would you be able to pick it up with a blood test? So focusing on getting this out there for glioblastoma, for the most malignant, most aggressive tumor, and that sort of clinical direction of travel. At the same time, we've got a huge, big science program, as long as people keep funding it, but to try and resolve these questions, because I think clinicians would like to know what is the signal coming from. It's more believable if you know what it is, and I think we'd like to add that information so people believe in it. A long answer, but anyway, thanks.
Thank you so much for elaborating it, because we all of us wanted to listen to this, because it is something so new, it's something so sci-fi, and I think people have got a lot of feedback right here, and even in our WhatsApp groups, it looks really exciting. Thank you so much. I think that Dr. Brandon, you have raised something very, very, very important, I think, and I guess it will be a game changer. And there's another thing right now which is very much relevant, is the COVID-19 pandemic that has made everything very chaotic, and I can tell you that even in our centers, our patients are waiting, and we know that we cannot take up that much of an OPD. We cannot see many of the outpatient, and many of them are being seen by local GPs. in countries like Pakistan, we have a lot of GPs who are covering the rural area, and unfortunately, they are not even well trained. I think that there's a need. It's a huge topic that we need to discuss later. But I think that if such kind of a testing is available, it will be much helpful to diagnose patient, and like you have said, triage in one way, so that we can actually know that what we are not going to miss any patient. And you are exactly right. It's so sometimes very unfortunate to see that people we cannot see everyone, and we are missing several of the patients. So obviously it's amazing. So there was I don't think that there are much studies available on liquid biopsy. So do you have, I guess, do you have any new something even more planning up for this liquid biopsy? Are you going to extend the furthest, extend the frontier of the study? Do you have any plan to like making a new something, a new twist in the story of this
Yeah.
liquid biopsy?
Well,
Yeah.
I mean, I think applying the same strategy to other cancers will be a big story, because it gets a lot more people interested. At the end of the day, brain tumors are a little bit esoteric because they don't affect that many people. So I think that's an important thing. The point you make about COVID and cancer is very valid. And when we talk to government ministers about this, the people who are making decisions about who spends the money in the health service, they like the idea that you could use a blood test to try and get through the backlog. So I think that's the twist just now is, the recovery from COVID, the recovery from cancer weight. I think it's a real opportunity. So that's, they're the two things we're after at the moment, are, post-COVID, this is the time to use it, and also pan-cancer. And so hopefully those two things together go global.
Well, there's another point that's very important that we have seen that there is also we have noticed probably because of more testing or whatever the reason is that it just seems that we have an increasing incidence of glioblastoma, especially we are also seeing glioblastoma in a younger age that we were not expecting for. And there's another point which is of great interest here is that WHO has changed the definition, and now the IDH wild type tumors, irrespective of their histological grade, are now termed as glioblastoma, and those with an IDH mutation, whatever the grade is, even the grade 4, they are known as the grade 4 IDH mutant astrocytomas. So how are you just going to look into these things like, more invasive tumors in the younger age group and increasing incidence? And do you think that this IDH mutation status also affects liquid biopsy, that you are saying that those tumors who are IDH mutant versus those who are IDH wild type?
I mean, there's loads of questions there. I mean, just referencing the stuff I showed you from Michael Poon at the beginning, I'd encourage anyone before they conclude that the rate of brain tumors is going up to really look at the data properly. And, the UK has always been very good at collecting data, and yet a lot of the data just doesn't have that information. So that when to say that the brain incidence of brain tumors is going up in young people is a pretty profoundly difficult thing to check, because the incidence in that population is incredibly low, and you'd have to observe it over decades to have any chance of knowing whether that was true. So I think we've always got to be alert for these. It feels at the moment sometimes that the incidence must be going up because we're getting busier, but we know year on year that the statistics look pretty common. So yeah, I think epidemiology needs done, on a big scale with good data, and it's really hard to get that, particularly in brain tumors. The IDH question is really interesting because it's got such a clear metabolic phenotype that this is exactly the sort of technology that should be able to detect that metabolic phenotype. And so something we did 2 or 3 years ago was we tried to, within the spectra, within the sort of 20,000 peaks and troughs, we tried to identify the IDH1 R132H signal, so the most common mutation, and we didn't succeed. So we couldn't identify a signal from either the metabolic phenotype or from the specific mutation. I suppose it's not a surprise we couldn't detect the actual mutation because the spectroscopy is not granular enough. Some people have picked up a metabolic signal in the blood for IDH. So maybe it is possible. We just need to try harder. But what we decided was just to do it differently. And that's where those electrochemical tests come in. Because if you're just interested in IDH, and actually there's a panel of cytokines that maybe in a year or whatever we can come back and talk to you about, but we've identified a group of cytokines in the blood that actually tell you what the tumor type is. So the spectroscopy will tell you you've got a tumor, and then this panel of cytokines will tell you with a pretty high degree of accuracy, or it seems to anyway, you've got an oligodendroglioma, you've got this or you've got that. So we can, if we put those two together, we need to put the cytokines onto an electrochemical chip. We need some sort of rapid way of detecting whether the cytokine's there or not, and we can apply that same technology for the IDH. So I think that's the next stage, or maybe not the next stage, but the next but one stage. And I think it will be good to be able to do, but we're not quite there yet.
Yeah, exactly. That will be for sure some game changer, because it's going to be really important. There's still, there are several centers who do not afford or who do not perform these
Yeah.
either stages. Many of the centers in here, since I belong to this low middle income country, so I think that it is something that's very incredibly important. And sometimes, I published a paper on surrogate markers to have an idea if the tumor is either wild type or a mutant one. It was before they updated this classification system. So there's another very a dilemma that I sometimes think is that we say that glioblastomas are heterogeneous. So if they are phenotypically heterogeneous, they should be genotypically heterogeneous as well,
Yeah.
although the genotypical landscape is constant. So how do you see things in this context?
Yeah, well, I think you touched on it in your question, right? So this test is a surrogate test of brain cancer. So we're not detecting brain cancer. We're detecting the body's response to brain cancer, and some of that might actually be bits of tumor, but most of it is the body's response to cancer. If you want to know that the person definitely has an IDH1 mutant tumor, at the moment you're going to have to biopsy them. You're going to have to stick a needle in the head and find out. It may be that the cell-free DNA approach does work over time, and it may be that ultimately you can take a sample of blood, find a bit of DNA, and sequence IDH. You can't do that at the moment, IDH1. You can't do that at the moment. But actually, if you took this triage test, the spectroscopy one, and then you only did the DNA test on the people who had a positive result, well, then that might work. So maybe it's actually collaboration, and it's creating a pipeline of liquid biopsy tests, which is the way forward. I don't think this is a competition to say one person's liquid biopsy is better than another person's. I think things, 5 years from now, we will be using 2 or 3 things. But yeah, I think it's a key thing. This is not a diagnostic. This is a triage. Both so that you don't over rely on it. If the test says you've got X or Y, you've got to decide whether you're confident enough to go ahead with your next course of treatment. In a 35-year-old with a tumor, I don't think that would be enough. I think you're going to have to do something else. In a 75-year-old who's got comorbidities, who you're not going to give temozolomide to anyway, maybe that's enough. So the context is important, I think, for how this gets adapted. And it'll be different in different countries and different healthcare systems.
Yes, exactly. So this is going to be really vast. These blood biomarkers and everything are very, very important. So I think that there's a lot of future in these blood biomarkers and the genetic levels, as well as there is a growing interest in precision medicine and the target therapy. In glioblastoma, especially, the target therapy has got a lot of roles, so that we somehow one day may be able to find that is when I recently came across this very wonderful publication on precision medicine for glioblastoma, they said that we might be able to, they actually target to make the tumor so much like a very benign or something like very chronic, that is within end-to-end course. If they cannot even, if they can get rid of it, at least they should make it much more less aggressive or something like this, so that there may be a lot of future. Because even there after so much time, we do not have much advances in the management of the glioblastomas, and we are just doing maximally F2 regimen that's been given, and whatever this the prognosis remains a little bleak. And now that the IDS mutant is a much better one than the IDS wild type, and now has been considered separately, not as a glioblastoma anymore. So thank you so much for spending a lot of your time and for all the questions and queries that you have very patiently elaborated in any way. I don't think that there is any ambiguity among our attendees for this very innovative new topic. If there's any question from the attendees, kindly put it in the chat box and we will be able to take up. Professor Nader Sanai is next. He's right now operating, and I think he will be joining us in 15 minutes. He got a little late, so I think that he will be joining us in a little more time. Dr. Paul, thank you so much for coming, I guess, and I think that this meeting, I will send you the recording as well. I've got a lot of feedback, and people are actually also watching it on YouTube live. So I think, yeah, exactly. So they are also sending feedback on the YouTube and contacting me from there as well. So if there is any question or comments, kindly put it in the chat link. I think there was another question somewhere. Someone someone from Mexico has written, yes, latest biomarkers are now in some of the Latin American countries. Dr. Marvin, can you please send your question again? Do you mean that these are available in your country, in the Latin America? Latest biomarkers are now in some Latin American countries by Dr. Marvin Salgado Perez. Dr. Marvin, will you please send your question again?
Camera shy.
I guess he has. I think that the message has been sent in an incomplete way. So I've received the half of it in the chat box. Dr. Marvin, if you are here, kindly resend your message in the chat box so that we can convey it. We can discuss it. Dr. Paul, do you really agree with the new classification system? Because they are just putting up new system every day because of this heterogeneity of the tumors, of the brain tumors. So we are like, ever since I've been in training, it is I don't know what time it I think this was the second or third time when we have read the new classification system for brain tumors. So how do you see this new genetic markers and the new classification system? Do you think that it is quite good based on?
Ultimately, we want better outcomes for patients. So the research that's getting done in the laboratory, that's what's informing the new classification system. So the suggestion is that in time that might help us understand the tumors better. I suppose it doesn't impact on our patients directly on a day-to-day basis, but maybe it will in the future. It's always a question with the clinical trials that have been done, whether if we treated the patients differently based on their molecular features, whether we might have identified that one treatment did work in this subgroup rather than another. So I think there's positives there. As you alluded to, not everyone does IDH1 analysis right now, and adding in more and more molecular phenotypes, it's going to take some time for people to catch up with that. But if precision medicine is our ultimate goal, then I suppose this is a route in that direction. Yeah.
Exactly. Professor Nathan, I today is delivering a lecture on insular gliomas because we really wanted him to deliver this lecture because of the Bergerson I classification system. But he has a lot of research in the phase zero clinical trials for glioblastoma, where he actually injects those target therapy type of drugs into those patients who are going to be operated on, just to see the pharmacodynamics and the pharmacokinetics of the particular drug. So he said that it is the one way forward to have an early knowledge of the pharmacodynamics and the pharmacokinetics of a given drug so that we can take it further. If they found it in the specimen they have resected from that patient, then it means that that particular drug has penetrated the BBB and it is now inside the tumor, so they can just take it on the one step further. So he actually also studied a few drugs that include the ribociclib, and he actually found that it was quite quite good in pharmacodynamically and pharmacokinetically, and also there was high free drug level in the blood. So he said that it is a wonderful drug, but alone cannot be something that is very that would not be very efficient for the regarding the treatment. So he said that we should rather give it with everolimus or any other drug combination like a cocktail. So how do you see the phase zero clinical trials? How do you see them, and do you think that it could be helpful
Well,
for
you're about to
patients?
talk. You're about to talk to the world expert, so I think I should make space for him. But I mean, you know, I think the work they're doing at Barrow is fantastic. It's something we'd like to replicate in Edinburgh, and we're working on doing that just now. So yeah, it seems an obvious thing to do, very difficult to do, and I think Professor Sana's sort of to be applauded for having achieved it really when so many other people have failed. It's good.
Yeah, exactly. It sounds really promising. So I think that it could be uh, something very new for us and very good for us. And even the target therapy basically sounds very promising to us. And maybe someday we will be able to have this. But I think that means that we need to have a lot of knowledge regarding, a lot of academic basis, and that we should read our patient from their molecular level, and neurosurgery, I don't think that neurosurgery is all about a craniotomy and resection of the particular tumor. It's all about reading and knowing what you are doing and what's taking and what's the origin of the lesions you are operating on, the tumor that you are operating on, so that you can just actually come to know about it. There are also raising interest in tumor vaccines, glioblastoma vaccines. I think that could be something of interest if they are successful in generating a tumor vaccine someday, maybe. There are things.
Yeah, I mean that's I think that the tumor vaccines. There's some data that was presented I think a couple of weeks ago in the US for the DC Vax trial. I don't think it's been published yet, but it seems to suggest that the people who received the vaccine um, had a significant they had a significant improvement in survival. It's still measured in months rather than years, but I think the immune system manipulating the immune system seems a quite exciting way to go, which is, I think the idea of neoadjuvant therapies, of doing something before surgery as well as something after, is the next big thing for glioblastomas, certainly, maybe even for gliomas. The earlier we can diagnose patients, the more tractable that is. Because if you present when you've got a big tumor and you've got lots of symptoms and you need lots of steroids, you're not going to get any immune therapy. We need to be picking up patients when they've got small tumors, and they can come off their steroids ideally. But that's a big step. So yeah, it'll be interesting to see how it goes. But that's sort of one of the drivers, I think, for me is trying to position patients and position the field to do some more exciting drug studies in due course.
Yeah, exactly. So I think there's also some sort of risk that those patients who have we usually always consider this thing that if a patient has one tumor, a systemic tumor, then if he present later on, then we should also always keep in mind that while we are expecting that that patient, since he has got a history of a systemic tumor, we do have this thing that he has got a metastasis, but it could be a primary tumor as well. So I think you can do better have an idea of how this could be.
I suppose Harsh's question alluded to that, is in terms of what changes over time. And it'll be interesting to see when we start assessing people with a spectroscopy test throughout the course of their treatment, how that changes. We have assessed people immediately pre and post surgery. There isn't a sudden drop off in the signal, which doesn't surprise me because it's that systemic response rather than the tumor. We're not assaying the tumor, but we don't have any data beyond that. So there's funding applications in at the moment to try and do that. But yeah, I think we suffer the same problem. People who've had a primary cancer, and then no one really seems to think that might be why they can't walk, and they don't scan their head. So it's fascinating to hear how similar the problems are. We're all dealing with the same clinical challenges. Yeah.
Yeah, exactly. So this is quite something. It's a very vast topic. I think that if we just keep on discussing and looking into it, then we are going to have a lot of questions and a lot of effort in that way. So again, I'm really thankful to you for sparing your time, and I think that we will certainly okay, thank you so much, Dr. Paul, for your for sparing your precious time for our talk today. It was so amazing to have you here and to discuss this very new approach and innovative approach. And we are looking forward to have the honor of inviting you again in our future webinars. So thank you so much again for coming.
Thanks for your time. Thanks for inviting me. Cheers.
Thank you, sir. Okay, we are waiting for Professor Nader Sanai, who is currently and doing in surgery. He's in surgery, so he will be joining us a little late, I guess in 10 to 15 minutes. I hope you can. I hope you can wait kindly so that we can have him. Hello, sir. Hello,
Hello.
sir. Hello, sir. How are you? Thank you so much for coming, sir. Thank you so much for you've been in your OR. I just came to know about it. I'm really sorry that for the for the inconvenience it caused to
No
have your.
problem.
Thank you so much, sir. It's a extra huge honor for us to have you here today. Dr. Niles and I, we are all a big, huge fan of yours. Everyone here in Pakistan and around the world as well. And we actually discussed the Burgess and I insular glioma zonal classification almost daily in our practice. And as trainees, I think that when I started my own training, it was the first question that was asked to me in the when I had a patient on insular glioma. So, sir, thank you so much for coming. It's like a huge wish of ours to have the privilege of listening to you today directly on the surgical strategies on insular glioma. And I think that Professor Sanai does not need any formal introduction, but for the sake of formality, I'm going to tell that he is right now the Chief Neurosurgical Oncology Director at the Ivy Brain Tumor Center and the Ann Arbor Professor of Neurological Surgery, Francis and Diana Tree Chair in Neurosurgical Oncology and at Barrows, and also the Director of Neurosurgery at Barrows Neurosurgical Institute. Sir, thank you so much. You are really welcome in the program. And the talk, your talk today is on the surgical strategies for insular gliomas. Sir, welcome to our Hubble show. And uh, sir, the floor is all yours now. You can share the slides.
Okay, well, thank you very much for the invitation. I'm sorry to keep anyone waiting. I actually was just finishing a biopsy on an insular glioma. So let's talk a little bit about this. Can you see my slides okay?
Yes, sir, we can. Thank you.
Okay, great. So I think insular gliomas in general can be the most challenging of all gliomas in terms of their anatomical location. But the challenge for insular glioma is not so much the technique, it's more the decision making, how aggressive to be, when to be aggressive, and how to use the biology in your favor. Most insular gliomas are actually more indolent than normal tumors. For whatever reason, the insula has a disproportionate number of or proportion of low-grade gliomas within it. We often see this in the clinic, non-enhancing tumors in the insula. They're often asymptomatic. It's not uncommon to see a patient who gets a scan like this for some head injury in 1988, where you could maybe visualize some sort of flare change in the left insula, and then 20 years later, they have a holo-insular glioma. So this is, I think, a comparatively indolent population of tumors, which means that there's a lot to lose. These patients often have very good neurological statuses, and because their tumors can be a little bit more slow growing, it means that we have to be particularly careful about harming them in an operation. The timing for operating on any low-grade glioma is pretty well established today. Years ago, before our generation, it was common to watch incidentally discovered gliomas or biopsy them and serially image them. But the data is pretty clear. This is a comparative study between two hospitals in Europe, where one tended to initially biopsy the tumor and one tended to initially resect. And the overall survival data is very obvious, favoring early resection. So just watching a tumor, even if it's asymptomatic, is no longer the standard of care. And the difference for patients in your intervention can mean many, many years of additional survival. And that data has been reproduced by other groups with exactly the same study design, again, showing early intervention favoring low grades. When we're talking to these patients, we have to be specific with them about what we're trying to accomplish. Obviously, with the extent of resection data that exists, we all know that we need to try to get all the tumor out if it's safe to do so. But there are levels to that, and it's important for patients to understand that sometimes we have to compromise extent of resection in favor of functionality. for low-grade gliomas, extent of resection is not just about survival, but it's also about malignant transformation. And for insular gliomas in particular, that's what you worry about. So what we know is that as we reduce the total tumor burden, we believe that the tumor microenvironment changes as a consequence of that. The total amount of tumor cells changes, and this leads to a disproportionate impact on risk of transformation. So the more tumor is removed and the lower the residual volume is, the better there is a profile for malignant transformation. What is also true for insular gliomas is that seizures remain a common presentation modality, and the patient's seizures or seizure profile can indicate the degree to which the tumor is under control. Seizures or new incident seizures will predict survival, they predict transformation rates, and greater extent of resection will modulate that seizure profile. And patients with 80, 90% extent of resection, this is data from our center several years ago, have a much better postoperative Engel status. Now, obviously within the insula, it's difficult to perform supratotal resections, but there are rare cases when that can happen, when you have a small insular glioma within the central portion of the insula. Supratotals are something to aspire towards, but the more likelihood of an insular glioma is that it will be completely resected, but not supra-complete. What we don't understand well about low grades in general is the impact of the molecular disease on the clinical performance. We know that when somebody has a 1p19q co-deleted tumor, their tumors grow more slowly. And when a tumor grows more slowly, it raises the bar for what we have to do as a surgeon. If you have a tumor growing very quickly and you remove 80, 90% of it, the impact you have on that tumor's recurrence profile is more profound than if a slow-growing tumor had 80, 90% extent of resection. And this is data that we've seen from many centers all around. So I think that what it says is that we have to look at tumor resection in context, and that extent of resection and surgical procedures can't be just looked at in isolation. Now, for insular gliomas, we know early intervention when it's a low grade is favorable. We know that there's a survival benefit and a transformation benefit when you're aggressive in your operation. What we need to learn about more now is the genetics of these tumors and how those genetics play with the clinical consequences of what we do. Insular gliomas can be high grade, and the data for high grade gliomas is similarly clear in terms of favoring intervention. Once upon a time, there were debates about whether it was even worth resecting a glioblastoma because it had such a poor survival. And that data, or the data to date, has been fairly clear, including this small randomized study, that a safe resection always improves overall survival compared to a non-resection or a biopsy. And probably the best data we have to date is from the ALA study in Germany, which was, as you know, a randomized study looking at 5-ALA versus no 5-ALA, and basically demonstrating not only does the 5-ALA work, which I think we can all recognize today as part of standard of care for high-grade gliomas, but that doubling of increased extent of resection doubled progression-free survival and substantially increased overall survival. So we can say with fair certainty that resections that are aggressive and safe benefit the patient. And there are many, many studies now that draw the same conclusion. And even if we can't get 100% of the tumor out, we know that even at the intermediate levels of resection, there is benefit, all the way down to about 78% volumetrically extended resection for a newly diagnosed glioblastoma. And the number is similar for recurrent glioblastoma. This is the data out of the Barrow that followed up that initial pivotal study out of UCSF. So we know that we need to aspire to at least 80% volumetrically for most gliomas. So if you look at a scan and you don't believe that you can reasonably achieve that, then those are the patients in which you should consider non-operative management strategies first. The same is true for anaplastic and grade 3 gliomas. One question that remains for insular gliomas and others is what the role of IDH mutation is in modulating extent of resection. There was an early study out of MD Anderson several years ago that suggested that if you had an IDH mutant high-grade glioma and you resected the flare, that led to a survival benefit. And that data hasn't really been reproduced reliably since then. However, there was this more creative study several years ago looking at the relationship between the proportion of flare and the proportion of enhancement. And they basically looked at these tumors in two ways. Those that are what they call proliferation dominant, where most of the tumor on the imaging was enhancing, and those where only the minority of it was enhancing and the rest of it was flare. And what they found was that in patients where most of it was enhancing, that's where resecting the flare had a clinical benefit. In the other category, the assumption is a lot of that flare is cytotoxic edema and not really tumor infiltration, so resecting it has less benefit. So for high-grade insular gliomas, obviously extent of resection improves overall survival. We will use this 80% threshold for newly diagnosed and recurrent glioblastoma patients. And of course, we need to be safe. Now, the safety aspect of it then takes us to the surgical side of this, which I think actually in many ways is the simpler part of the conversation. Traditionally, there have been two general categories of approaches to insular gliomas, a transcortical route and a transsylvian route. And there are advantages to each. Obviously, if you're going transcortical, you need to know whether that cortex is safe to transgress. And obviously, if you're going transsylvian, you need to be careful of the vasculature. For many years, this was probably something less prominent in the literature. There were reports like this from Strom looking at general categories of mesial temporal tumors, including insular gliomas. And he was probably one of the first to publish on the fact that when you go transsylvian for these mesial temporal tumors, there is a significant risk of vascular injury, which in his series led to hemiparesis and aphasia. As many people know now, there's a simple way of thinking about insular anatomy and dividing it into zones. It basically involves a plane that goes through the sylvian fissure and a perpendicular plane in the coronal plane that goes through the foramen of Monro. And so this gives you 4 zones, kind of going clockwise from the sort of anterior superior component all the way around 1, 2, 3, 4. And so when you think about these zones, each of them present with them a little bit different of a profile with respect to the insular exposure that you can get through a transsylvian versus transcortical route, the surgical freedom, and the surgical window. This is a study published by one of our residents here, Arnaud Benet, several years ago. So the point is that depending upon the location of the insular glioma, it may lend itself to a different approach. So here's a typical patient, a 74-year-old male with a dominant hemisphere, left-sided insular enhancing lesion. This is occupying effectively all of the insula. And there are several options that could be considered here. Obviously, observation and needle biopsy are probably not the initial steps most of us would take. So here we have 2 similar tumors, the one on the left being approached through a transsylvian route, the one on the right through a transcortical route. And in both cases, intraoperative mapping can be useful. In the case on the left, you use it mostly on the mesial aspect of the tumor, where you're looking for the internal capsule and the descending cortical spinal tracts as you get to the medial margin. And on the one on the right, you're using it initially to identify a safe trajectory, a safe corridor cortically, and then you're also using it on the subcortical side, especially for internal capsule. Both approaches are acceptable. Both approaches can yield excellent surgical and clinical results. Both approaches can preserve language and motor function. So in part, it comes down to what you're comfortable with. And in part, it comes down to the patient and some of the aspects specific to the patient. So I don't think that there's any right or wrong answer with respect to which you choose. And in my practice and here at the Barrow, it's probably about 50-50. When we look at our experience, of the last 150 cases, the proportion of high grade versus low grade is similar. The tumor volumes on average are similar. However, the Sylvian and Transsylvian cases, they tend to be larger tumors, in part because when an insular glioma is large, that's actually easier to do because the tumor has displaced the anatomy to make room for itself. So getting into it through the Sylvian fissure is quite straightforward. There's not a lot of dissection. And then once you're in the tumor, you're using the tumor space against itself. You can see the distribution of zones of the tumors that were involved in these cases, and you could see that zones 2 and 3 were favored for the transcortical. The clinical results for these approaches are the same, and in our hands, the radiographic results are the same. We did, however, identify that zone 2 tumors tended to be associated with more perioperative ischemia on imaging. This wasn't always clinically relevant, but radiographically on diffusion imaging, it was statistically significant. And this probably has to do with the fact that when you're going to a zone 2 tumor, if you take a transsylvian route, you have to pull up on the Sylvian fissure and you have to dissect the fissure very distally. And so those two maneuvers put the vasculature of the fissure at risk, either from just simple compression over time or actual vascular injury, and less commonly through spasm. So I think it speaks to the need to use a transcortical route for some of these more posterior tumors. But a transsylvian route, which is the route we took on that case example, is a very well tolerated route. You can dissect the fissure proximal to distal or distal to proximal. You use the tumor and the space that it's created against itself, staying within that capsule, and really trying to preserve the peel margins around it. In about 15% of insular gliomas, the medial lenticular striates are embedded within the tumor. So the tumor doesn't displace them medially, it actually carries them with it. And so those are the cases that you really worry about with respect to lenticular striate injury. What I generally tell our trainees is that if you're seeing the lenticular striates, it's already too late. What you ideally want to do is not see them. Take the tumor resection up until them or before that. And that's where subcortical awake or asleep motor mapping can be very helpful. Ultimately, that patient did well. All of these patients will generally wake up with some degree of worsening hemiparesis, worsening language deficit, and you have to prepare them for that. But you can also prepare them for its resolution because it will resolve with time. So in terms of optimizing any glioma operation, I think I would want to just end with 6 technical points. The first is to always try to employ subarachnoid planes like you saw I did in that last case with this transsylvian approach. The second is to carefully select the point of entry for where you're entering the brain. What peel margin are you transecting for any glioma, and is it the safest one? The third is to pay attention to patient positioning and position patients in ways where gravity and the natural falling of structures works to your advantage. We talked about fluorescence-guided surgery and the importance of that. Intraoperative ultrasound is a rising or resurging technology that was popular in the 1980s, then fell out of favor in the 90s, 2000s, and I think more recently with some of the devices is coming back into vogue. And of course, stimulation mapping, which I think is a standard adjunct that's needed for any major brain tumor center. So we talked about Transylvanian approaches to zone 2 insular gliomas and the risk of that. Arachnoidal dissection, though, as a general technique for neurosurgeons, is just something that you have to be proficient in. We all, as brain tumor surgeons, need to have the same skill set as vascular surgeons. This is why, for example, in my career, I did a fellowship with Spetzler before I started my practice, because I wanted to see how a vascular surgeon approaches brain tumors. And in fact, in many ways, it's quite a bit different. So having these tools in your armamentarium, being facile with not just going through the cortex or through the brain, but around it, is really, really important and something that everyone needs to have at their disposal. Decision-making about entry point is very important as well. So look at this scan on the left. This is a grade 1 glioma. This is a juvenile polycystic astrocytoma in a young female. That means that if you resect this completely, it's likely cured. But getting to it is not straightforward, and the route to get to this is through a lateral supracerebellar approach, which you see in the video, where you come above the cerebellum, under the tentorium, then you go above the trochlear nerve, and the first point of entry is the pulvinar. And the pulvinar of the thalamus is a very, very acceptable entry point with low morbidity, and it will get you right there to this trajectory so you can remove this. Gravity retraction and positioning is also very, very important. Here we're taking an interhemispheric approach to a thalamic glioma. You can position interhemispheric straight up and down, but the better way to do it is horizontally. That way, the corpus callosum is positioned horizontally for you, as you see here. Your hands are in line with the fissure, which is in line with your eyes, and one hemisphere is dropping away. We don't use any fixed retraction at the Barrow. I haven't used a fixed retractor system in probably 12 years. You don't need it. What you need are proper instruments, including in this case, we're using lighted bipolars. And you get into the lateral ventricle through the corpus callosum and you enter the thalamic pia through the ventricle. So this can be a very, very straightforward operation, and it begins with positioning. High-grade gliomas are particularly suitable for 5-ALA fluorescence-guided surgery. I think that if it's available to you, there's no reason not to use it. It provides more information. It can validate your intraoperative assessments. It complements neuronavigation when there's brain shift. We have other devices here in development to use for low-grade gliomas to visualize the fluorescence, because it can't be macroscopically visualized, but with the proper magnifier, like this handheld confocal device you see in the lower right, you can visualize microscopic protoporphyrin 9 and even quantify it. Intraoperative ultrasound, I think, is an underrated device. With the technology that exists today, there's incredible resolution. Here you see an insular glioma being approached with the lenticular striates on the mesial aspect of that tumor, and then mid-resection, you see how close they are to the lenticular striate margin. So this can all be done in real time, and as you can see here, it's being merged with the preoperative MRI neuronavigation. And finally, stimulation mapping, which we talked about, is a very important adjunct to have for any type of tumor, particularly insular gliomas. It's important to be facile with it, to develop a great relationship with your neuroanesthesiologist, to have the right protocols in place in your operating room so that everybody on the operating room team is comfortable with the mapping case. Some cases are awake, some cases are asleep. At our center, it's probably 50-50. But the point is to have this toolkit, because for any tumor, including insulars, it's particularly important. And the data supports that very robustly. There's a meta-analysis from Hugh Defoe and Mitch Berger showing what we know, which is that it reduces the long-term neurological deficit rate, and it improves the ability to get aggressive extensive resection in highly eloquent tumors. So overall, what I would stress for insular glioma management is that you have to look at the tumor in context. It is not one size fits all. the biology, the clinical presentation, the anatomy, all have to be taken into consideration before you make a decision. The strategies that we use should always be early, always be aggressive, but always be safe. And that's where decision-making and intraoperative adjuncts can be helpful. And I've shown you some of these adjuncts, both in terms of techniques and technologies that help us become better brain tumor surgeons, better glioma surgeons, better neurosurgeons, and just need to be part of all of our daily evolution. So with that, I will conclude. Thank you for your attention and happy to take any questions.
Thank you so much, sir, for the amazing lecture. It really means a lot to us and to everyone who is listening right now. We have got a lot of people watching this live on YouTube, and I think there will be an equal number or even higher who will be watching the recording lately. So again, thank you so much, sir, for sparing your time. I know you've been so busy in the OR, and again, it's a huge thing for us. I think there is just one question by Dr. Harshad Parikh right now. He has asked that in which cases you feel that only biopsy is fine and you don't go for resection. In which cases
Yeah,
do you
that's a
think
great
that?
question. So what I would say is if you look at for example, if you have a non-enhancing insular glioma, like the case that I had this morning, and you see that that tumor is extending beyond the insula into other regions, into the anterior perforating substance, into the brainstem, into regions where you can't reasonably resect it safely. You have to make an assessment as to whether or not you can get 80% of it out safely. If the answer is no, then it's better to try other approaches. One approach, for example, something that Hugh Defoe has published on and others, is to, in a low grade, is to biopsy the patient and then put them on Temodar. And for some patients, they'll have a partial response to Temodar, and some of the eloquent regions where the tumor exists will shift and respond to the Temodar over the course of months to years. And the profile of the tumor anatomically will change, and it will become a more resectable tumor. So there are strategies to kind of slow play the decision-making in order to give the patient a better surgical result.
Amazing. Thank you so much for the very elaborate answer, sir. It actually came to my mind that when we were planning this webinar, actually, sir, these webinars are under the direction and supervision of the WFNS Education and Training Committee, and I'm honored to be the organizer of all these series of webinars. So when I first came across this idea to have this, and I discussed it with Professor Luis Borba. I had that in mind. I was much intrigued with your phase 0 clinical trials and the targeted therapy for glioblastoma, sir. So those were really, like you had just mentioned, the Temodar, and I just listened to one of your talks where you said that in brain surgery, we just have this Temodar option most of the time, and we do not have anything in particular in addition to that might be able to help us in managing these glioblastomas. That was so intriguing, and I think that I may have the honor of inviting you again for a talk on that aspect as well.
Of course, thank you. I think the WFNS is a really important organization. I'm part of it as well with the Brain Tumor Committee, and looking forward to in-person and additional seminars. So happy to help however I can.
Thank you so much, sir. It's a huge thing for me, sir. I'm also a part of the executive committee of the AANS tumor section, which has been chaired by Professor Isabella Germano. So it is something that very exciting for me. Thank you so much, sir. And I just really appreciate the fact that you are not just, this is going, you like, such as like you are beyond this craniotomy and resection, and you are also dealing the tumor from the molecular level. So this is so much huge that you're treating from the very start to the very end and just finding the targeted therapy. I guess targeted therapy is going to be our future if we just one day find it. So.
Well, thank you very much. We're all in this together, trying to fight this very difficult disease. We have to do it however we can surgically, scientifically. So I appreciate all your efforts and hope we can talk again soon.
Thank you so much, sir. Again, thank you so much for spending your time from the OR, and sorry for the inconvenience that we had this meeting on the day when you were using the OR. So again, sir, a big thanks and a lot of best regards and greetings from Pakistan as well. That's my home country.
Thank you very much. And again, appreciate the opportunity. Looking forward to hearing from everyone soon.
Thank you so much, sir. We are also looking forward, and I think that we are also planning another webinar already with Professor Luis Borba, who is traveling today, and he could not unfortunately make it today to be in the webinar. So I think we are going to arrange it again on brain tumors. We are also running a course for medical students and young junior neurosurgeons like me who have just completed my training. So I think this course has been divided into 12 modules. We are just touching up the important topics. So I think that we might be able to have you again for this again. Thank you so much, sir.
Of course. Thank you, everyone. Have a good day.
Have a good day, sir. Thank you so much. Time to wrap up the session. Thank you so much, everyone who came today and who joined us today. So I hope to see you again soon. Kindly subscribe to our YouTube channel and to our WhatsApp group and to just stay updated. Again, thank you so much. I'm closing up the meeting and I'm looking forward for your positive and